Hello everyone. In this class, we'll try to learn about what are pulmonary function tests. The assessment of the type and degree of functional impairment caused by various diseases may be as important as diagnosis, management, and prognosis of some of the pulmonary disorders as detailed history with röntgenographic, bacteriological, and pathological examination. Though some of the pulmonary function tests require sophisticated equipment and procedures, most of the tests are simple, non-invasive, and inexpensive. Classification of the PFTs. Various tests are grouped under three broad categories. One, the test that assess ventilation, that is lung volume, lung capacities, and mechanics of breathing. Second, the test that assess the gas exchange in the lungs. And third is assessment of the pulmonary blood flow and pressure. In tests that assess ventilation, we have lung volumes and lung capacities. In lung volumes, with tidal volume, inspiratory reserve volume, expiratory reserve volume, and residual volume. The capacities are vital capacity, inspiratory capacity, functional residual capacity, and total lung capacity. While measuring mechanics, uh, the timing vital capacity, maximum mid expiratory flow rate, maximum voluntary ventilation, peak expiratory flow rate, flow volume curve, closing volume, maximal expiratory pressure, maximal inspiratory pressures are important. And tests that assess gas exchange in the lungs are assessment of ventilation perfusion matching, assessment of diffusing capacity, and determination of arterial blood gases. So then we can assess the pulmonary blood flow and pressure. Uses of pulmonary function tests. They help in diagnosis of respiratory dysfunctions, monitoring the progress of the disease, evaluating the efficacy of the treatment, assessing the health status of a person prior to recruitment to military or police services, determining the efficacy of physical training, studying the prevalence of respiratory diseases in the community or respiratory industrial hazards, then assessing the respiratory fitness of the patients for general anesthesia prior to surgery, and finalizing the medical legal cases to decide fitness or degree of compensation. The normal values of various parameter of spirometry in adult male subjects, tidal volume is 500 ml, inspiratory reserve volume is 3000 ml, expiratory reserve volume is 1100 ml, forced vital capacity 4600 ml, FE1 is more than 80% of FVC. FE1 to FVC ratio is 0.7 to 0.8. Peak expiratory flow rate is around 400 to 600 liters per minute. RMV is 6, that is minute ventilation is 6000 ml. Maximum voluntary ventilation is 125 to 170 liters per minute. Then breathing reserve is, which is a difference between MEV and resting minute ventilation is around 115 to 160 per minute. Then dyspneic index is should be no more than 90%. If it is less than 60%, it indicates dyspnea at the rest. All lung volumes and capacities are about 15 to 20% less in females. Tidal volume. Tidal volume is the volume of gas inspired or expired during quiet breathing. This is around 500 ml in adults, and 150 ml of this fills the airway from the nose and mouth down to the respiratory bronchioles, and this amount does not take part in gas exchange. This is called as anatomical dead space. The remaining volume, that is 350 ml, is available for alveolar ventilation. Inspiratory reserve volume is the volume of air inspired with maximal inspiratory effort in excess of the tidal volume is inspiratory reserve volume. The normal value of IRV is 3.3 liters in men and 1.9 liters in women. Expiratory reserve volume, it is the volume of air that can be expired with maximum expiratory effort after passive expiration is the expiratory reserve volume. The normal value of ERV is 1 liter in men and 0.7 liter in women. Residual volume, the volume of air remaining in the lungs at the end of maximum expiratory effort, is the residual volume. The normal value of residual volume in men is 1.2 liter and in women is 1.1 liter. So this is the graph showing various lung volumes and capacities. So here you can note down the tidal volume. That is, this is the inspiratory reserve volume. This is the inspiratory capacity. That is inspiratory reserve volume plus tidal volume. So then this is expiratory reserve volume, and this is the vital capacity. And the vital capacity plus residual volume is total lung capacity. Vital capacity. The maximum volume of air that can be expired after maximal inspiratory effort is called vital capacity. The normal value of vital capacity in men about 4 liters and in women is about 3 liters. Forced vital capacity is the total volume expired with greatest force and speed after maximal inspiration is the forced vital capacity. Forced vital capacity differs very little from vital capacity in normal subject, but it is proportionately more reduced when there is an airway obstruction with air trapping. Inspiratory capacity, this is the volume of gas that can be inspired from resting expiratory level. So this is IRV plus TV. Functional residual capacity is the volume of air remaining in the lungs at the end of resting expiratory level. The total lung capacity is the volume of air present in the lungs at the end of maximal inspiration is the total lung capacity. The normal value is 6 liters in men and in women it is 4.2 liters. The measurement of the following respiratory parameters gives a fair idea of mechanics of breathing in clinical practice. The timed vital capacity. So this is also called as forced expiratory volume in first second, that is in 1 second. So this is defined as a percentage of air expired in the specified time. For example, FEV1, FEV in first second. This test measures the vital capacity in relation to time and gives the portion of the vital capacity expired in specified time, say 1 or 2 or 3 seconds. This is an index of air flow rate. The normal condition 80 to 85% of the forced vital capacity is expired in the first second, 95% in 2 seconds and 97% in 3 seconds. It is one of the most useful tests to detect generalized airway obstruction. Maximum mid-expiratory flow rate, that is MMFR. This is the maximum flow rate achieved during the middle third of the total expired volume. This is expressed as forced expiratory flow at 25 to 75% of the lung volume. That is, it is also called as FEF 25 to 75%. So FEF 25 to 75% indicates the patency of small airways. The measurement of the flow rate between 200 to 1200 ml, that is FEF 200 to 1200 in liters per second, indicates patency of larger airways. Maximum voluntary ventilation, this is also called as a maximum breathing capacity. MVV indicates the maximum volume of gas that can be breathed per minute by maximal voluntary effort. The normal value of MVV in adult male is 150 liters per minute and in adult it is 125 liters per minute. Peak expiratory flow rate. It is the maximum velocity in liters per minute with which the air is forced out of the lungs. PEFR can be read directly from the dial of the peak flow meter. The normal value of PEFR is 400 to 600 liters per minute or 6 to 10 liters per second. Maximum expiratory flow volume curve. Because of the limitation of the FEV1, certain other tests are performed to detect airway obstruction in its early phase. This include Vmax 75, response of maximum expiratory flow rate, volume, curve to inhalation of helium and closing volume. The MEFVC flow is plotted against volume exhaled. Vmax 75 is the volume achieved after exhaling 75% of the total FVC. Closing volume test detects the small airway obstruction by measuring the volume of gas remaining in the lung after closure of small airways in the gravity-dependent lung areas. Maximal inspiratory pressure is when patient exhales completely to residual volume and then tries to inspire maximally against an occluded airway. The pressure generated in this maneuver is called as mean inspiratory pressure or maximal inspiratory pressure. It assesses the strength of the inspiratory muscles. Maximal expiratory pressure, that is MEP. The patient inhales completely to TLC and then tries to expire maximally against an occluded airway. The pressure generated in this maneuver is maximal expiratory pressure. It assesses the strength of expiratory muscles. Measurement of ventilatory function. Most of the pulmonary functions are measured by spirometry. A recording spirometer is a spirometer with recording kymograph. The spirometer consists of a hollow double-walled vessel. The space between these two walls contains water to maintain an airtight seal. In the space between two walls is placed an inverted hollow cylinder or cylindrical bell of 9 liters capacity. The bell is attached to a counterbalance with a chain which passes over a pulley. The counterbalance carries a pen for writing on kymograph paper. The kymograph operates at a speed of 60 to 1200 mm per minute. The spirometer records the volume and capacities of the lungs. However, nowadays pulmonary functions are measured by computerized spirometer. The residual volume, functional residual capacity, total lung capacity cannot be measured by spirometry as they include volume of gases present in the lungs even after maximal expiration. They are measured by helium dilution technique and total body plethysmography. Abnormalities of ventilation. There are two major patterns of ventilatory abnormalities, restrictive and obstructive pattern. Features of obstructive disease. In obstructive lung disease, total lung capacity is normal or increased. Residual volume is elevated due to the trapping of air during expiration. The ratio of the residual volume to TLC is increased. The vital capacity is frequently decreased, not due to the decrease in the lung volumes, but due to increased residual volume. FEV1 is less than 80% of the total lung capacity. The FEV1 to FVC ratio decreases and MMFR decreases. Features of restrictive disease. There is a decreased total lung capacity, decreased vital capacity, decreased residual volume. The preservation of forced expiratory flow rates, especially FEV1 expressed as percentage of FVC, is normal or sometimes supernormal. Restrictive parenchymal dysfunction, there will be reduced total lung capacity, reduced residual volume, reduced vital capacity, or there can be normal or increased FEV1 to FVC ratio. So this is diagram showing the volume of air which is exhaled against the time. So this is 1 second cutoff. In normally 80% of the air is expelled in first second. In restrictive lung diseases, the amount of FVC is reduced. Okay, and in FEV, the FEV1 is drastically reduced. The list of common obstructive and restrictive diseases. The obstructive diseases are asthma, COPD, that is chronic bronchitis, emphysema, bronchiectasis, bronchiolitis, and cystic fibrosis. And some of the restrictive disorders in that parenchymal or extra parenchymal diseases. Uh, in parenchymal restrictive disease are the pulmonary fibrosis, pneumoconiosis, radiation-induced interstitial lung diseases, and in extraparenchymal, neuromuscular disease like myasthenia gravis, paralysis of the diaphragm, muscular dystrophy, and chest wall diseases like kyphoscoliosis, obesity, and ankylosing spondylitis. The alteration in lung volume and capacities. The conditions that decrease vital capacity are first because of the loss of functioning of the lung tissue or loss of distensibility of the lung tissue or pleura. The loss of functioning in the lung tissue are the interstitial pulmonary fibrosis, chest deformity, neuromuscular diseases, and thickened pleura. The loss of distensibility is going to occur in atelectasis, consolidation, pulmonary edema, and pulmonary resection. The conditions that decrease static lung compliance are pulmonary edema, chronic pulmonary congestion, kyphoscoliosis, fibrothorax, interstitial fibrosis, and atelectasis. The conditions that increase airway resistance are bronchial asthma, chronic bronchitis, emphysema. Other diseases that are characterized by airway obstruction. The patients with increased airway resistance are usually dyspneic, which depends on the severity of the airway obstruction. So the conditions that decrease forced vital capacity are the FVC is reduced in conditions in which there is obstruction to the airway resulting in air trapping, like in case of bronchial asthma. And conditions that decreases the FEV1 are FEV1. FEV1 is an important test to detect generalized airway obstruction. As it is effort dependent, it should be performed properly to get the appropriate results. However, it is not specific for detecting small airway obstruction. FEV1 is reduced in obstructive lung disease of the lung, as in bronchial asthma. Change in FE1 to FVC ratio. The ratio of FE1 to FVC is approximately between 0.75 to 0.8. So this is a more sensitive indicator of airway obstruction than FVC or FEV1 alone. So alteration in the MMFR or FEF 25 to 75. This is a sensitive indicator for patency of small airways. This is slowed in small airway obstruction. Variation in FEF 200 to 1200, it is the flow rate between 200 and 1200 ml of FVC. So it is one of the sensitive indicator of patency of larger airways. It is slowed in large airway obstruction. Reduction in the peak expiratory flow rate, as it measures the peak expiratory flow rate during peak of expiration, it obviously decreases in airway obstruction. MMFR and FEF 200 to 1200 are better indicators than PEFR. Decline in maximal ventilation. The normal value of maximum voluntary ventilation is 150 liters in males and 125 liters in female. However, the value can be fallacious if the patient does not cooperate or fails to use maximum effort to carry out the test. The MVV decreases in patients with subjective dyspnea. Then assessment of the gas exchange. So here ventilation perfusion relationship, that is the uniformity of distribution of inspired air is measured by nitrogen washout method. An alveolar gas sample after 7 minutes of breathing oxygen normally contains less than 2.5% of nitrogen. The higher the percentage of nitrogen in the alveolar sample, the greater the degree of non-uniformity of distribution of inspired gas. The perfusion is also not uniform in erect posture due to the effect of gravity. The normal ventilation perfusion ratio is 0.8, but greater degree of non-uniform perfusion occurs in diseases like pulmonary embolism and diseases that destroy lung tissues. The arterial blood gas tension is primarily affected by the relationship of ventilation with perfusion. Alteration in the ventilation perfusion ratio uh, mainly affects PaO2 and PaCO2. Coming to diffusion. Diffusion is the physical process by which gas move across a membrane from region of higher partial pressure to the region of lower partial pressure. In lungs, oxygen moves from alveoli to the pulmonary capillaries to combine with hemoglobin. Similarly, carbon dioxide moves in the opposite direction. The diffusing capacity of carbon dioxide is 20 times more than that of oxygen. Therefore, diffusion problems usually do not produce carbon dioxide retention. The measurement of arterial blood gas tension is essential in the evaluation of pulmonary functions. The normal value of PaO2 is 90 to 95 mmHg and PaCO2 is 36 to 44 mm of Hg. Hypoxemia. Decreased PaO2 is called as hypoxemia. It occurs in four conditions. Decrease inspired PO2 hypoventilation, or it can be in shunting when desaturated blood effectively bypasses the oxygenation at alveolar capillary membrane, and it is common in cyanotic congenital heart disease. Then ventilation perfusion mismatching, as that occurs in COPD or asthma. Conditions that decrease pulmonary diffusing capacity when the total surface area of the alveolar capillary membrane is reduced, as it occurs in emphysema, pulmonary embolism, thrombosis of pulmonary capillaries uh, following surgical removal of the lung tissues, and when there is a defect in the alveolar capillary membrane, that is thickening of the membrane, which occurs in asbestosis, sarcoidosis, progressive systemic sclerosis, collagen diseases, interstitial edema, interstitial fibrosis, and diffuse metastatic lesions of the lung. Or it can occur in increased pulmonary diffusing capacity during the exercise. How do you sample the gas for the analysis? So alveolar gas sampling of alveolar air is done uh, by two methods. One is Haldane-Priestley method. The subject makes a forced expiration through a long narrow tube about 3 feet length and 2.5 centimeter diameter. He closes the mouthpiece with his tongue. The sample of air contained near the mouthpiece of the tube is withdrawn via side tube into the sampling tube. Thus, the last to be expelled from the lung is considered as alveolar air. Then Rann-Otis method. So this is a procedure of a continuous sampling. Breathing through mouthpiece fitted with inspiratory and expiratory valves collects a sample of end tidal volume. The samples are passed into gas analyzers. Sampling of expired air. Douglas bag. It is used for this purpose. A two-way valve is fixed to the Douglas bag and then connected to the mouth of the subject. The atmospheric air is inhaled and then exhaled into the bag. Respiratory gas analysis. The samples of inspired air mixed with expired air from the Douglas bag and the alveolar air, which is collected from Haldane-Priestley method, are taken for analysis of partial pressure of oxygen, carbon dioxide, and nitrogen. The gas analyzers are available to give the partial pressure of different gases. Then blood gas analysis. The oxygen content of the blood is determined by Haldane's gas analyzer. The venous blood is collected and sent for analysis. The oxygen carrying capacity of the blood is estimated by Vance-like gasometric method. The partial pressure of carbon dioxide is also determined with the help of gasometers. Then assessment of pulmonary circulation, pulmonary blood flow and pressure. The measurement of pressures, vascular resistance, blood volume, and distribution of blood flow in the pulmonary and systemic circuits help in detecting veno-arterial shunt, vascular occlusion, and decreased pulmonary capillary volume. The pulmonary vasculature accommodates about 5 liters per minute of right ventricular output. The vessels that are comparatively thin-walled and provide less resistance to flow in comparison to systemic vessels. The normal mean pulmonary artery pressure is 15 millimeters of Hg. In upright posture, the arterial pressure is the lowest at the apex and highest at the lung bases. Assessment of pulmonary blood flow. Assessment of pulmonary circulation depends upon measuring the pulmonary vascular pressures and cardiac output. These measurements are usually done in intensive care units with facilities of invasive monitoring. With a flow-directed pulmonary arterial Swan-Ganz catheter, the pulmonary arterial and pulmonary capillary wedge pressures can be measured directly. The cardiac output is obtained by thermodilution method, and the pulmonary vascular resistance is calculated as PVR is equal to 80, the difference between PAP and PCW divided by cardiac output, where PAP is mean pulmonary arterial pressure in mmHg and PCW is pulmonary capillary wedge pressure in mmHg, and CO is cardiac output in liters per minute. The normal PVR, that is pulmonary vascular resistance, is 50 to 150 dynes into second per 5 raised to centimeter. The disturbances in the pulmonary circulation. The pulmonary vascular resistance increases by 4 different mechanisms. One is pulmonary vasoconstriction. The pulmonary arterial or arteriolar vasoconstriction in response to alveolar hypoxia increases PVR. The pulmonary thromboembolism. Intramural thrombi in pulmonary vessels decreases the luminal cross-sectional area and increases PVR. Vascular hypertrophy. Proliferation of smooth muscle within the vessel wall decreases the luminal cross-sectional area and increases PVR. Pulmonary injury. The destruction of the small pulmonary vessels either by scarring or loss of alveolar wall decreases the total cross-sectional area of the pulmonary vascular bed and increases the PVR. Increase in the PVR increases the pulmonary arterial pressure, that in turn decreases the right ventricular output. Conditions that increase PVR. In heart diseases, cardiac conditions that elevate left atrial pressure, such as mitral stenosis, increases the PVR. Lung diseases like respiratory conditions that cause chronic pulmonary hypoxemia increases the PVR, as it is seen in the COPD, that is chronic obstructive pulmonary diseases, interstitial lung diseases, chest wall diseases like in kyphoscoliosis, obesity, hypoventilation, sleep apnea syndrome, and the diseases that affecting the pulmonary vessels like recurrent pulmonary embolism or scleroderma that occludes small pulmonary arteries and arterioles. Then respiratory causes of hypoxemia. The causes of hypoxemia that are classified into respiratory and non-respiratory. Respiratory dysfunction is the most common cause of hypoxemia in adults. Non-respiratory causes include anemia, carbon monoxide poisoning, and decrease in oxygen tension as it occurs at high altitude. The respiratory causes of hypoxemia may be due to regional hypoventilation or occlusion of the major artery in the lungs by a large blood clot or by shunts or generalized hypoventilation and diffusion block. Generalized hypoventilation is the common cause of hypoxemia that occurs when alveolar ventilation is low. This occurs in chronic obstructive pulmonary diseases such as emphysema or in depressed respiration as a result of head injury or drug overdose, for example, morphine. As ventilation is depressed, there is associated increase in the arterial PCO2 with a simultaneous decrease in arterial pH. However, the differentiating feature is that in generalized hypoventilation, the alveolar arterial gradient is normal. That is, alveolar arterial oxygen gradient is normal. The cause of hypoxia is entirely due to generalized hypoventilation. It is best corrected by placing a patient on the mechanical ventilator breathing room air. Diffusion block. The infrequent cause of hypoxemia is diffusion block. This occurs when diffusion distance across the alveolar capillary membrane is increased, or permeability of the alveolar capillary membrane is reduced. It is characterized by low PaO2, high alveolar and arterial oxygen gradient, and high PaCO2. Pulmonary edema is among the common causes of diffusion block. So this is in brief about pulmonary function test. Thank you.